I'm Dr. David Casey. I'm chair of the Department of Psychiatry here at UofL, and welcome everyone to our Grand Rounds presentation for today. Today we have a very special guest as our presenter, Robert Campbell, the second MD, or Rob as we affectionately know him. Dr. Campbell graduated from the University of Florida and the University of Florida School of Medicine. He originally trained in general surgery and then did a postgraduate fellowship in thoracic and cardiovascular surgery before coming to Louisville and working here as a surgeon for a number of years before he saw the light, and did another residency in psychiatry with us here at UofL, following which he joined our faculty and served here in various capacities, most notably working in emergency psychiatry service at EPS. While here, Dr. Campbell was involved in many different ventures, including EPS and others, very interested in psychiatric education, worked and mentored many students and residents, widely known as one of the most knowledgeable faculty members, helped out with board preparation in a number of ways for our residents, and worked extensively in the field of addictions also. Later, Dr. Campbell moved to Columbus, Ohio, where he's worked in various capacities, both inpatient and outpatient, most notably as a staff psychiatrist at Twin Valley Behavioral Health, which is a state facility roughly similar to our Central State, although also with a number of forensic responsibilities. He has done too many presentations on too many topics to keep track of or count. He remains on our clinical faculty and also serves on the clinical faculty of Ohio State and other institutions, and continues to be heavily involved in medical education with students and residents from a number of facilities in Ohio coming to serve with him and at that facility. Today, he's going to talk about stress reactions and the mental health worker as second victim. So, Rob, it's great to have you back, and I'll turn it over to you.
Thank you very much, David. So, I first became interested in this topic of stress disorders in health workers in general when I was at Jackson Memorial, because it affected me personally. So Jackson Memorial is one of the largest hospitals in the country. It's a 2,000-bed hospital that serves over 5 million people in the South Florida and the Caribbean. It's also the only hospital in the world or at least in the country, that trains U.S. Army surgeons in combat surgery before they go to various parts around the world. Certainly when I was there from 1990 to 1992, the Middle East was a big deal. The Gulf War was going on and that sort of thing. So I first became interested in this because I was affected personally by stress disorders. The cocaine wars were still going on, and there was an endless stream of gunshot wounds and other trauma on a daily basis. Now, we did so much trauma that we had about 10,000 trauma admissions a year. And what you see there is the Ryder Trauma Center, which is 4 stories high. It can land 4 helicopters at a time, and you can operate on about 20 people at one time. And some weekend nights when I was there, we would get 15 or 20 gunshot wounds in a 24-hour period. Once again, it was during the cocaine wars, the trauma patients range from toddlers. It's not just a level 1 adult center, but it's also a level 1 pediatric trauma center. And we would get anywhere from toddlers to the elderly, whether it be from a drive-by shooting or a shootout between federal agents and Pablo Escobar's henchmen. And I operated on many of them. I also operated on a lot of cocaine body packers who got acutely ill from ruptured condoms filled with cocaine and would have to go to the operating room. So needless to say, it was stressful for the entire healthcare team at Jackson, especially those dealing with the trauma. And one night in particular, I noticed that I was becoming more and more stressed out on a daily basis. Our call schedule was such that the cardiothoracic and the trauma fellows spent every other night in the hospital for that 2-year period. And there was one period of time when my counterpart fellow went to Europe for 2 weeks. I had to stay in the hospital for 2 weeks. So about every third day, my wife would bring me food and fresh underwear. I had just lost a 16-year-old gang member on the operating room table to a horrendous vena cava injury, and I just became stressed out and went to my call room and cried for an hour. Fortunately, there we had great support from a peer support team, the likes of which we will discuss near the end of this presentation when we developed it at the University of Louisville. And so that's when I became interested in first responder PTSD. In 2017, I was the keynote speaker at the Kentucky Trauma Nurse Symposium given at UofL, our university hospital. And what we discussed was stress disorders among the healthcare workers treating critically ill or acutely injured patient population in the state of Kentucky. And so with the help of many people on the staff at University Hospital, we started our own peer support program for stressed staff members due to the repeated trauma and everything from repeated trauma to doctors and nurses who made grievous mistakes that dealt with patient care that nearly cost patients their lives, and sometimes it did. So then after I moved back home to Columbus, Ohio, I became the medical director of a Columbus Springs East, which is a psychiatric hospital here in town. And I started a peer support program there for mental health workers. I became the director for the Help for Heroes program, which is a 30-day inpatient first responder PTSD program that included law enforcement personnel, firefighters, paramedics, radio dispatchers, as well as active military personnel. Some of the people we helped and some of them we couldn't, but there was great satisfaction knowing that many of these people were able to return to work duties, and in helping them, I think we helped ourselves. So that's a little bit about me. And the two things I'm proudest of, I think, is being the director, as far as this subject, being the director of the Help for Heroes program, and then also being the co-founder and former medical advisor for the Code Lavender program, which still flourishes at the University Hospital. So we're going to talk about cases that I either treat. Now, of course, the pictures are not accurate, the names are not accurate, but the cases are patients I've treated or I've gleaned from the literature, or I have had fellow attendings here at Twin Valley relate to me. And so this is Pam. She's a psychiatric nurse. She's 42 years old with over 15 years of experience caring for severely mentally ill patients. And I directed this in the first person because I think that there's people in the audience here that can relate. So you are considered by your peers and the psychiatric staff to be one of the strongest and most compassionate mental health workers on your 26-bed unit. Today, you are the charge nurse and is particularly busy on your shift with multiple admissions, transfers, and small fires to put out. And one of your sickest patients is Dale. He's a 19-year-old male who has early onset schizophrenia, and he's been on your unit multiple times in the past, and you've always taken great care of him. And he was recently doing well on clozapine, but stopped his medication several weeks ago. So you have just finished helping the senior psychiatric resident on the unit with Dale's admission. Dale had been highly agitated since arrival on the unit earlier in the afternoon. And you know from prior experience that Dale can be extremely violent. So for whatever reason, Dale doesn't like the psychiatric resident and backs her into the corner of the room. He quickly escalates, and despite your considerable de-escalation skills, Dale attacks the resident, and you call a code violet and help quickly arrives. So Dale refuses oral medications and must be taken to the seclusion room, where he continues to struggle with multiple personnel. Unfortunately, he requires 4-point restraints for the administration of medication, something you really do on your unit as far as having to place people into restraints. He's given intramuscular emergency medications, Haldol, Ativan, and Benadryl. He is initially checked by you and the psychiatric resident, and the appropriate paperwork is completed. So Dale is placed on one-to-one observation consistent with your protocol and for patients being in restraints. And after you believe Dale is suitably medicated, you attempt to remove him from those restraints about 30 minutes later. And Dale must be placed back into the 4-point restraints for the time being. So you leave the seclusion room to go check on other patients. And within 10 minutes, a PCA assigned to watching Dale cries out, "Call a code blue. I don't think Dale is breathing." So Dale is quickly taken out of the restraints, and you confirm that he has no pulse or respiration. CPR is initiated, but he can't be resuscitated and he is pronounced dead after a lengthy code. So throughout the code, you have kept your cool, but now reality sets in and you collapse in a nearby chair thinking about any errors that you or your team made that may have cost this young patient his life. So you start to think about your own 14-year-old and 17-year-old sons at home and cry inconsolably. You are relieved from the rest of your shift and call your husband to come pick you up because you are too distraught to drive. You cannot get the events that occurred out of your mind. You sleep fitfully that night and have a terrible nightmare. Back at the hospital, Dale's parents are demanding answers as to what could have possibly occurred to cause their son to die while in restraints on a unit dedicated to helping him. You stay off work for the rest of the week thinking that a major investigation of the incident is inevitable. Eventually, a root cause analysis is undertaken to determine if any errors occurred. The committee finds that all protocols were followed appropriately. Dale's autopsy does not reveal any other cause of death other than an irreversible cardiorespiratory arrest. Still, you are racked with guilt, even though you rationalize that you did everything by the book and cared to the best of your ability for Dale up to his last breath. For the first time in your career, you question your skills as a nurse. You feel overwhelmed, helpless, and hopeless about the situation. You keep your children close to you for fear that something is now going to happen to them. You feel as if no other nurse in the world has ever had a patient die while on their watch. So you feel anxious, depressed, and grief-stricken all at the same time. You are constantly nauseated and can't eat. You feel extremely tired, but you can't sleep. Despite your best efforts, you can't get the image of Dale struggling in his restraints only to die minutes later. You begin to have memory problems and forgetfulness, and your attention span is only a few seconds. You blame the hospital, you blame your fellow staff, but mostly you blame yourself. You take a leave of absence. Dale's parents had trusted you and let them down. So nothing seems to help. You think about quitting nursing, a career that you dearly loved for many years. A month goes by and you feel no better. Your nightmares continue and you begin to have flashbacks of the entire event. You have even contemplated suicide because you're just that miserable. You seek counseling and begin to see a psychiatrist and a therapist. So you go to the therapist and the psychiatrist and you are diagnosed with a post-traumatic stress disorder and you never return to work as a psychiatric nursing. And in fact, Pam never returned to nursing, period. So this is what we call a second victim. So the root of the problem, the relationship between a mental health care worker and their patient is often very close, and this proximity can expose staff to the distress and trauma experienced by the patients. Mental health care professional caseloads can often include patients who have been affected by trauma, violence, abuse, fear, and chronic mental illness, combined with a myriad of other physical and mental health issues. So what are second victims? Second victims are healthcare workers, and in this case, mental health care workers, who are providers, who are involved in unanticipated adverse patient events, such as clinical errors, or who have been traumatized by things that have happened or things that they have seen at work. So if anybody can relate to this out there, maybe we can hear from them a little bit later. So stress and trauma terminology, there's a great debate on the correct terminology for this. There's vicarious trauma, there's acute stress reaction or post-traumatic stress disorder, depending on the timing, the time frame between the onset of the trauma and your reaction. There's secondary traumatic stress disorder. And although there's some discrepancy in the definitions, most researchers agree that having a clear and distinct understanding of each term will help how we identify, respond, and prevent the emotional aspect of stress and trauma at work. And one of the new terms, compassion fatigue, used to be termed a term we used all the time, and now there's a movement in the literature, and we call it now empathic distress fatigue. So vicarious trauma and compassion fatigue, vicarious trauma or empathic distress fatigue is often described as an occupational hazard for health workers during their engagement with traumatized and chronically ill patients. And over time, the mental health workers may begin to mirror the biopsychosocial effects shown by their patients. Vicarious trauma can impact the physical and mental health of health workers, permeating all aspects of work and home life. So over time, even character and personal belief systems can be altered, resulting in a drastic change in spirituality and major psychological needs. Secondary trauma and indirect trauma. Secondary indirect trauma describes how a mental health care worker provider begins to experience similar symptoms as the patient, whereby the traumatizing event of the patient becomes a traumatizing event for the nurse and other healthcare provider. The symptoms of secondary trauma and vicarious trauma are essentially the same, but there is a difference in that secondary trauma can occur unexpectedly and suddenly after just one case, whereas vicarious trauma occurs over time. There's traumatic countertransference. A traumatic countertransference occurs when a healthcare provider, and when I say provider, I mean all aspects of mental health, from the environmental services to the social workers to the unit secretaries on the unit. So traumatic countertransference relates to a patient in such a way that they unconsciously connect the patient with an existing relationship in their own life. This can occur in many situations, not just in medical or psychiatric settings, where there is a connection between patients or people based on empathy. This can be harmful sometimes because as a healthcare provider, we want you to be empathic, but the relation should be professional and not because the patient, let's say, reminds you of your mother. So some of the common stress reactions, whether there's behavioral ones, and I'm not going to read all these because you can see them, but there's changes in activity levels, there's decreased efficiency and effectiveness, you have trouble communicating, you develop sometimes a gallows humor aspect, which was my defense mechanism at Jackson Memorial. You have become irritable, you have outbursts of anger, you can't rest, you have changes in your eating habits, sleep patterns, your job performance declines. You become tearful, crying, sometimes at work and usually at home. Increased incidence of substance use happens. You become hypervigilant about safety. There's avoidance of activities or places that trigger memories, and accident-prone behavior then begins to increase. Some of the psychological or emotional aspects, you may feel heroic and euphoric or invulnerable prior to an event. You may develop denial. You may have anxiety or fear. You worry about the safety of yourself or others. There's irritability or anger that develops. You become restless, sad, moody, grief or depression. Anhedonia sets in sometimes. Vivid or distressing dreams occur. You get the so-called survivor guilt, which was very, very present when I was treating the active military personnel last year in the other hospital. You feel overwhelmed, helpless, or hopeless. You feel isolated, lost, lonely, or abandoned. You become apathetic. You over-identify with survivors, and you feel misunderstood or unappreciated. Some of the physical common stress reaction include increased heart rate and respirations, increased blood pressure. Pretty much any symptom that you can think of becomes increased. One of our nurses began to lose her hair after a stressful event when she was attacked by a patient. Right now, we have approximately 60 mental health workers in this particular hospital. They're on leave of absence from patient violence against them. So it's on any given day, we have 3 to 5 code violet calls that require medications, restraints. We actually have a police force here, but they don't carry weapons on the unit. But about 20 to 30 people respond to a code violet, and sometimes it requires even more than that. So some of the common stress reactions that are in the cognitive area, you develop memory problems or forgetfulness. You become disoriented, confused, slowed thinking. You can't calculate. You have difficulty concentrating. Your attention span goes down. You have a loss of objectivity, and you just can't stop thinking about the incident or the disaster that occurred. Some of the common stress reactions are social. You withdraw or isolate from people. You have difficulty listening, difficulty sharing ideas, difficulty engaging in mutual problem solving. You blame, you criticize, you become intolerant of group processes. I've had some of my patients or healthcare workers that I've helped who, after 20 years being in Alcoholics Anonymous or something, they just stop going, they relapse, and they just can't stand being in a group process anymore. You have difficulty in giving or accepting support or help, and you become impatient and or disrespectful. So screening mental health care providers for potential maladaptive stress responses. There are multiple checklists and questionnaires available to help us screen patients or our fellow workers. There's acute stress disorder, which occurs within 1 month after exposure to an extreme traumatic stressor. And then PTSD is basically the continuation of acute distress disorder type symptoms after 1 month. And this is what Pam was diagnosed with. So the tool that I use, there's a civilian form and there is a military form, and it's basically the PTSD clinical checklist for the DSM-5, and it is abbreviated PCL-5. And so I'm not going to go through all these questions because most of you are familiar with this. It basically just kind of outlines the symptoms that Pam developed in our scenario. So how do you use it? Well, it really does help a great deal. The range in scores, you divide up or you add up all of the scores. It ranges from 0 to 80. I've had active military personnel that score in the 60s and 70s. No one's hit 80 yet, but a total score of 33 or higher suggests the patient needs at least further assessment to confirm a diagnosis. So psychiatric nurses, let's see, there are approximately 45,000 psychiatric registered nurses in the US. There's an estimated 40,000 vacant nursing positions. Psychiatric healthcare workers are repeatedly exposed to work-related stresses that include addressing the specific needs of mentally ill patients, dealing with high-stress situations involving patient care on a day-to-day basis, addressing and sometimes struggling with many ethical issues that arise, and then taking care of the needs of the family members. And family members, my wife was an ICU nurse for many years, a supervisor, and she said that with her job, the most stressful aspect of it was dealing with family members and not the day-to-day care of the intensive care patient. So this is a part of the mental health crisis in the country, is just a shortage. You can see there on the left, we have marriage and family therapists, psychiatrists, mental health counselors, social workers, and psychologists. The nurses aren't even included in there. And yet on the left, we have a national shortage of at least 200,000 mental health care workers. For psychiatrists, there are more psychiatrists that are needed right now that are even available by a factor of about 1.5 to 1. So let's go back to Pam and look at the psychiatric healthcare workers and PTSD. So studies have shown that psychiatric and general med surg healthcare workers report an equivalent amount of stress in their life outside the hospital. 20 to 25% of psychiatric healthcare workers, when screened, are positive for symptoms of PTSD, compared with 15% of the med surg healthcare workers. So this is the same comparative group. Shows no difference in the incidence of having a history of pre-existing anxiety or depression. So therefore, it must be the job exposure to trauma. This is case number 2. This is a case that I dealt with, not in Louisville, but in Columbus. Jonathan is a psychiatric resident. He says, you are a 24-year-old PGY3 psychiatric resident doing your required year of outpatient psychiatry. And one of your favorite patients, Sheila, has borderline personality disorder, and you've been conducting a DBT with her. She has had a recent crisis in her life and leaves a message for you on a Friday afternoon, just as the clinic is closing. So you call her back, but there's no answer. You leave a voicemail and then depart for the day. Sheila calls you back shortly after you've left, and you find out on Monday morning that over the weekend, Sheila has committed suicide. This kind of hits home with me. If you recall, certainly the faculty members will recall, that as an intern, I had a patient at Norton that within 24 hours of leaving, everybody thought, including her family, that she was doing great and back to her baseline. And she went home and within 24 hours committed suicide. And I found out on a Monday. She went home on a Friday. I went and I found out on a Monday, and I was devastated. And one of our great residents in my class, Jocelyn Kendari, she was so upset about how I was upset that she started developing some stress reactions too. And so Dr. Spurgeon got us, so that we can kind of decompress on it, got us to do a grand rounds presentation. Unfortunately, it didn't count for my fourth year grand rounds, but it was an intern presentation, and the faculty input was tremendous, because virtually every faculty member in there shared their story of patient suicide. And that is one of the biggest stressors for stress and decompensation in psychiatrists. You know, it's interesting. People always ask me, why did I go into psychiatry from surgery? And of course, I did that because I injured my arm and I couldn't operate any longer, and that was traumatic enough. But when I interviewed at UofL, I had a really great conversation with Dr. Tasman, and we talked about the similarities between the two. I know a lot of psychiatrists whose second choice was surgery, and I know a lot of surgeons whose second choice was psychiatry. And what Dr. Tasman taught me was that one, there's that unique doctor-patient relationship, but more than any other specialty, I think, psychiatrists and surgeons believe that they are the bridge between disease and sickness and health. You know, you can be stuck in the middle of the Sahara Desert as a psychiatrist and help people with psychotherapy. And with the necessary tools as a surgeon, you can operate on someone and maybe save their life, let's say from a ruptured appendix, without really the help of anybody else. And no one, I don't think, takes death harder than surgeons and psychiatrists in their patient population. So Jonathan becomes a second victim, and he did finish his residency, but he had to have quite a bit of therapy and counseling to get through, to struggle. So there are higher jobs or higher rates of jobs absenteeism than in the public sector. Now, levels of psychological stress are up to 10 times higher than in the general population. And there's a greatly increased risk for being the victim of workplace violence with mental health care workers and with healthcare workers in general. There's an increased risk for career abandonment, reduced work competency, work overload, work team instability, career burnout, and increased interpersonal problems at home. Pam ended up getting divorced after about 2 years with her mental health struggles. PTSD symptoms. So an event is classified as traumatic when it triggers specific PTSD symptoms, and these symptoms are observed either during or immediately after the event, the so-called peri-traumatic stage. Several days later, the post-traumatic stage. And at the peri-traumatic stage, those that are affected report symptoms of distress, which include anxiety and guilt, dissociation, where people, places, and things just don't seem real anymore. At the post-traumatic stage, those that are affected describe symptoms of revival, stimulus avoidance, dulling of general responsiveness, hyperarousal, and many of the other symptoms that Pam and Jonathan experienced. So this is Alex. This one hits home for me because my grandson works here on the forensics unit with the most violent patients we have. We have a forensics unit that has some patients that have been there for over 40 years from the prison system. They're deemed too dangerous to go back into society. And so I worry about him on a day-to-day basis because of the workplace violence that they experience. So Alex is a 34-year-old patient care associate on an inpatient forensic psychiatric unit. And he's serving lunch one day and a psychotic antisocial patient unexpectedly assaults him, breaking your jaw and nose. Your injuries require surgery and you do not return to work for 6 weeks. You very reluctantly then return to work, but 2 weeks later, you develop overwhelming fear of your attacker and you resign and you never return to any type of hospital work again. So this is a quote from Alex, and he says, "It's sad really because I didn't used to be easily frightened, but after that I started locking my car doors before I even started the engine. And I became more cautious and anxious when there was someone who looked like they might mean trouble. It's annoying. I can't control it. If I had a choice, I'd go back to the way I used to be. I don't want to go on being so easily frightened." And an interviewer who was talking to him says, "You mean you were always on the alert?" And he says, "Well, I don't know. How can I put it? Let's say on the lookout all the time." And so once again, he had 8 years of experience. He had had sessions of violence before, but he had never been severely injured until this time. So here's some helpful screening questions when you're taking the history of an at-risk patient or an at-risk staff member in discussing with them. In the past month, have you directly experienced a traumatic event yourself? Have you witnessed one and others, such as close family members or colleagues or peers at work or a friend? If so, have you experienced any of the following? Nightmares. You tried hard, avoidance, tried hard not to think about the event. You've been hyper vigilant. You felt derealization or dissociation. You felt guilty or unable to stop yourself or blaming yourself or others for the event. And if your patient answers yes to 3 of these 5, they need to probably go on and have their PTSD assessed or potential PTSD assessed by a mental health provider. So here's some other cases that I've either been involved in or been told about. There's Stephanie, who is a 39-year-old social worker with a private therapy practice. And at the end of the day, everybody is going home except she and her patient, and she's basically raped by her client. There's Thomas, who's a 28-year-old PGY3 psychiatric resident working on an inpatient unit. And after entering a patient's room, he finds that his patient has committed suicide by hanging himself with the bathroom door with a bedsheet. Now, I do a lot of expert witness work in the field of psychiatry, and this is basically the names and the ages have been changed, but this is a case from Pittsburgh where this very thing happened. And of course, the family is blaming the hospital, and staff members are beginning to blame each other. They had just documented that this patient was not suicidal, but he was. And so then the next one is Jennifer. She's a 24-year-old unit clerk who was kidnapped at gunpoint by a former mental patient on her inpatient unit and was held hostage in her car in the parking lot for over 4 hours. And this actually happened here in town about a year ago at one of the other hospitals. So psychological first aid. I don't know if Steve Littman is on the line here, but he and I presented. We gave a presentation at the Louisville Youth Violence Symposium over on the West Side a few years ago, and we talked about stress disorders in the inner city. The incidence of PTSD in the inner city approaches that, or maybe even exceeds that of a combat veteran. And it's from repeated exposure to trauma. And so there's an evidence-based informed approach to providing individuals who following a crisis event. This is a psychological first aid, or PFE, is recommended by both the World Health Organization and the International Red Cross to be utilized by first responders at catastrophic events. And when we say first responders, sometimes we're second responders. It's the friends and neighbors or witnesses at a scene who actually become first responders, sometimes providing very heroic acts. And the aim of the PFA is to reduce initial stress of a traumatic event and promote adaptive functioning and coping. Current techniques of PFA were developed in the wake of tragedies such as war, natural disaster, and most recently school shootings. More and more school teachers are taught how to render PFA to their students should an active shooting situation occur. When there was a devastating earthquake in Afghanistan about 10 years ago, and everybody from the World Health Organization to Doctors Without Borders went in, And they actually began teaching the natives, because there were so many people involved, thousands of people were killed. They began teaching the resident population how to administer PFA, because there simply weren't enough mental health workers available to do so. So the PFA assumes that individuals may experience a broad range of reactions following a traumatic event, but that not all individuals will develop mental health problems. This goes back to resilience. You know, in my active military military population that I've treated, it was very rare to actually get an officer with a college education in for evaluation or treatment of PTSD. It tended to be enlisted men, and of course the enlisted men included everybody from medics to snipers. And there was a very high suicide rate, as we know, in the military and veterans and active military personnel because of their traumatic experiences. So what are the core actions? Well, there's contact and engagement. You initiate contact with the targeted individuals in a non-intrusive, compassionate, and helpful manner. Safety and comfort, you enhance immediately. You get them to a safe situation, get them out of the trauma situation. You enhance immediate and ongoing safety if any of the elements of dangerousness remain at the scene. Stabilization, calm and orient the emotionally overwhelmed or disoriented person who has been traumatized by an event. And then information gathering, identify immediate needs and concerns, gather in additional information, and tailor PFA interventions. Do not ask for a detailed description of the traumatic event itself, as this can prove to be counterproductive and worsen the psychological status of a traumatized person. The military learned the hard way that a psychological debriefing, as they called it, where a patient or a soldier went through in great detail what had happened to him, and this triggered severe post-traumatic stress disorder in many of these people. This can also happen with a root cause analysis, where the involved personnel are brought in, and they do have to go over every excruciating detail, trying to find ways to prevent this from happening again. Individual strategies to avoid stress and trauma, they can include improved self-awareness, better management of work and life balance, better personal and social connections, motivation to learn and grow professionally and emotionally, use of reflective practices such as mindfulness and yoga. I know in our new psychiatric unit at UofL, we had the wisdom to put in a meditation room that the staff could use to just kind of get away from it for a while, listen to music, read, and just contemplate what's going on in their life. Many healthcare providers will experience compassion satisfaction, which is when the provider has positive feelings associated with the belief that they have contributed or helped in some way. Individual and organizational processes that enhance compassion and satisfaction can significantly help protect an individual from work-related stress and trauma. So the conclusions and comments from the mental health care workers themselves is that the mental health care workers regularly face traumatic events in their work. They are at risk for developing acute stress disorder and PTSD. And we need organizational support. And this exists in some institutions. I know it existed at UofL after we started our peer support program, but in some places it's often inappropriate or insufficient. You know, a lot of this developed from the airline industry. It used to be that if a pilot had a near miss, he was fired or she was fired. And same with flight attendants. And they learned that that didn't prevent airplane accidents. And so what they did was come up with a totally separate safety policy, looking at system failures as opposed to individual failures. And the same thing happens in the healthcare industry, where many of the things that happen as far as, let's say, a nurse or a doctor makes a medication error, it's administered, the patient dies or has a near-death experience. Looking back on it, well, yeah, you can blame the individuals, I suppose, if you want to, but you can also blame some of the systems, the network that you're working in too. One of my experiences was that I was putting in a central line on a pediatric patient when I was in Galveston, and I was the pediatric surgery chief resident. And the nurse mistakenly handed me potassium chloride instead of saline to flush the central line. And so I should have looked at the bottle. She should have looked at the bottle more closely, and we should have agreed upon what would happen. And so I gave this patient a big bolus of potassium chloride when he was about 10 years old, and he immediately had a cardiac arrest. And we started the usual protocols of reversing this, but I ended up having to put this kid on ECMO to support him until we could dialyze him to get the potassium out of him. So we have to recognize the traumatic events faced by mental health workers and knowing which activities help them cope with that exposure. This can enable other workers to develop support programs in their own settings, and we're going to talk about that in just a little bit. So from an organizational level, there should be policies and procedures that recognize and prevent risk factors for vicarious and secondary trauma. Notably, this should include the provision of educational material about mental health disorders and the support systems that are available to all staff. Organizations can also make sure that managers encourage professional development, as well as making sure staff maintain a proper work and life balance. Positive encouragement and the continuing appreciation of the work being done can be beneficial in promoting a supportive and safe workplace for all. Peer support for the second victim, I use here. I'm on the peer support program, or what's all called staff response team here for traumatic events for staff members. Second victim transpersonal care model, and this provides a structure for alleviating individual healthcare providers harm using a second victim caring moment. And this intervention offers comfort measures, alleviation of pain and suffering, promotion of healing using a model of escalating support. And it begins with surveillance during high-risk clinical events by leadership and colleagues that are knowledgeable about the second victim phenomenon. So peer support teams were specifically designed to provide confidential peer-to-peer support for healthcare workers reacting to a stressful clinical event. And this addresses the workers' unique needs using a three-tiered model of comprehensive support. Our so-called, what's termed our Code Lavender program at UofL was a three-tiered program where tier one was a departmental support and leadership mentoring. Tier two, we had peer support experts that had been through a week-long class. And then tier three is when I became involved even more so, and that was screening some of the second victims for the need for ongoing mental health care, whether it be through the EAP program or through individually or group psychotherapy. So tier one provides immediate emotional first aid from colleagues and or supervisors in the clinician's department or unit. Unit leaders are expected to monitor staff after a potentially distressing clinical event. Peer support specialists have been educated on the second victim phenomena and the immediate supportive interventions to consider. Tier two, both interventions use basic elements, tier one and tier two, use basic elements of support incorporating a caring moment, and they are based on the knowledge that individual clinicians may require differing intensity and duration of support during emotional recovery. There's one-on-one interventions are held as soon as the second victim is identified. Then there are debriefings, and I don't mean the psychological debriefings. I mean the support debriefings for the peer support staff are scheduled to ensure personnel are involved in the event that can participate. Debriefings are facilitated by a senior peer support team, leaders, many times including myself. There was quite a few times when I would leave EPS for a brief encounter with an impacted staff member, and help facilitate and screen and then let the peer support team take over. One of the most important members on our teams was the chaplaincy. And in fact, we'll go over this in a minute, but the initiator code lavender at the UofL University Hospital, the operator will call the chaplaincy. Chaplain will do an assessment and then call me. Sometimes I came in from home in the middle of the night to see an impacted person. I was working one day in EPS, and a young Hispanic mother came in full cardiac arrest from a pulmonary embolism, and she was 36 weeks gestation, and she could not be resuscitated, but there were still fetal heart tones. And so the OB service did an emergency section right in the room 9, and there were several impacted nurses, all of whom had young children at home or were pregnant themselves, and they had to take some time off. They had a rough time. Tier 3 ensures availability and prompt access to professional counseling and guidance services for healthcare workers requiring support beyond the capabilities of the trained peer support system. So we're getting down to the end. I don't know, a lot of you guys might remember Nick Rodman, who was a police officer, a very beloved police officer who came into the emergency department frequently. And he had a brother that was also a police officer for LMPD, and then his father is actually the senior instructor at the police academy. So he came in with a severe head injury injured in the line of duty during a car chase over on the west side, and he was T-boned by the person he was actually chasing, who looped around and ran a red light and injured him severely. And so he was in the ICU. He required 2 craniotomies, but he became brain dead and had to be taken off of life support. Well, there were probably on any given day 200 just officers and their spouses everywhere in the surgery waiting room who were trying to console and comfort each other. The police chaplain was there, the police chief was there, and my good friend Debbie Judd, who is the director of the operating room services, said our staff are becoming traumatized completely by what they're witnessing out there. One of the neurosurgery nurse practitioners ended up transferring to the outpatient clinic because she was dealing with so much trauma from family members and police officer staff. And so as traumatic as that was, when Nick finally expired, they placed him on a gurney with an American flag over him. And from the ICU all the way to the ambulance that was awaiting him to take him to the funeral home, it was lined with police officers saluting him. And they went right through the emergency room, and the emergency room staff was just devastated. So later, actually during his stay there, many most people knew I was a psychiatrist, and they would stop me in the hall and say, I'm distressed, or I have a staff member who's distressed. What can we do? And so I approached a few people, and I said, why don't we start a peer support program here like we had and where I was at Jackson Memorial? And that was met with a rounding applause, and we started seeing people using the code lavender system. Now, I was actually getting my oil changed in my truck over at one of the dealerships a couple of weeks after this. And lo and behold, Nick Rodman's father was in there, and he had a picture on his uniform because, like I say, he's the senior instructor at the police academy. And I said, "Did you know Nick?" He said, "Nick was my son." And I told him, I said, "We have staff members at University Hospital that are wanting to leave nursing or change their positions or something because of taking care of your son." He says, "Oh, don't do that. You guys help too many people." And so what he ended up doing, he came over and he ended up talking to some of the traumatized people and saying, we really need you. Don't give up your positions. Steve or Nick would not want you to do this sort of thing. And that's kind of how the Code Lavender program was born there. And then about a year later, you might recognize Steve Bolton here, who was a nurse extraordinaire on 5 South. Well, he was out hunting alone, fell from a deer stand about 20 feet, broke his neck, and laid there on the ground in freezing temperatures for hours until someone figured out at home that they couldn't contact him. They went looking for him and found him. They medevaced him to UofL. He was in the ICU. His family was conscious enough and gracious enough to allow people to go in briefly and visit him. And I can remember there was a line, probably 50 people long, filing through the ICU just to say goodbye to him. He was probably the most popular nurse in the hospital, and certainly the most popular preceptor to the nursing program, the nursing programs that rotate through there. So we started the Code Lavender program, and you can see on the right, it can be used by any staff when a traumatic event has occurred and emotional debriefings is necessary. Staff then contacts the on-call chaplain. Chaplain comes over, does an assessment with peer support trained people that we had 24/7 at the University Hospital. And they will determine if it's a true Code Lavender, and then I would be called and we would determine if I needed to see the person then, see the person later on, or whatever. The chaplaincy, trauma social workers, and the committee, we had a committee for the Code Lavender, would then decide. We would kind of have our own debriefing and make sure that we had to follow the parameters necessary to support these people. So here's my bibliography, and that's it. Questions or comments, but mostly what I want to hear is if any of you out in the audience want to share with us any personal experiences and how you relate to this presentation. And with that, I conclude it. Thank you.
Please use the Q&A function or raise your hand or something, and we'll recognize you and bring you up.
Dr. Caudell, I think Dr. Lippman has his hand raised in the attendees. I don't know if you want to move him into the panelist section.
I have. Dr. Lippman, you need to accept my invitation.
There, is that better?
That's better.
Yeah, well, I certainly am glad to see you, Rob. It's wonderful to see you and have you back here. There's a great topic, something that affects us all. I've certainly had suicides on the ward as a resident. One of the things you said reminded me of a kid that we discharged one day from 5 East at about 10 or 11 o'clock, and about, oh, I don't know, an hour and a half later, the police called me and said, we found him swimming dead in the river.
Yeah.
There's a prescription bottle with your name on it.
Yep. I believe that is true. And I also had a patient that I took care of at Norton's, and then and I said, this is a guy who at some point is going to commit suicide. Then he was at University Hospital, and I didn't take care of him there. And he left and promptly went across the street and dove off of the parking garage at the university.
Oh, I
So,
remember that.
huh?
I remember that.
Yeah, in my residency, I had 3 patients that I took care of that within that were anywhere from 24 hours to 7 days committed suicide, and on every one of them, except for the fellow that jumped off the parking garage, I thought that they were doing well. Everybody thought they were doing well. My attendings thought they were doing well. The family thought so. You just can't predict who's going to do this.
I could tell you an institutional trauma story.
Okay.
Jewish hospital, when I first got here in 76 at Louisville, they said, well, Jewish hospital doesn't take psych patients these days. Now, I don't know if they do now or not, but whatever it was, reportedly, this is a story I've only heard, not seen. I heard, they told me, well, somebody jumped out of the window at Jewish a couple of years ago, and so they won't take any psychiatric stuff.
Yeah.
So it affected the whole hospital.
Oh, yeah. Oh, I believe that. I believe that. Yeah. In fact, I used to do a lot of cardiac surgery over at Jewish Hospital, and we would get, well, actually our group did all of the cardiac and thoracic and vascular surgery for the inmate population for the state of Kentucky. They would come over, and quite a few of them would have some psychiatric problems, and there was no one at the time, and I don't know if this is true anymore. There was even doing psychiatric consults at Jewish. When I first joined the faculty there, Dr. Tasman was trying to get it so that I could do the psych consults over at Jewish, but that kind of fell through. They didn't seem to be too interested in it. So yeah,
Later on, we did it with another guy. I forgot his name right now, but one of our other fellows did it one time.
Did you?
Yeah,
Well,
for years.
yeah.
I forgot his name. I can picture him, but I can't say his name.
Okay.
Probably Dave would remember it.
You know, I think there was also just this calendar year, I think there was a suicide of a patient that left Norton that committed suicide, I think within 24 or 48 hours. I don't know if Dr. Wong's here or if any of the residents that took care of that patient are here that want to, if they feel comfortable sharing about that experience. I know we talked about it during Chief's Hour, but I don't know if there was any other communications about that.
Rob, we had a number of people that did consults of various kinds of Jewish over the years, and we did have some differences of opinion with the administration as it existed at that time about how to approach the problem. Marty Klafik and Bob Frierson were there for many years, and others. So I wondered if you could return to the topic of debriefing and the sort of the counterintuitive negative effects that may accrue in a debriefing situation. Why you think it may seem to be effective in the short run, but in the long run may have a variety of negative effects.
Yeah, getting a traumatized staff member to go over in detail right then kind of solidifies some of their trauma experience. And so when we would do an intervention or a debriefing, it wasn't a so-called psychological debriefing like the military used to do. It was basically not so much what happened, but how has this affected you and your other staff members? And so what we used was psychological first aid. And I think, Steve, you probably remember when we went over to the Louisville Youth Symposium on Violence, and how many people were interested in actually learning PFA. And the local Red Cross teaches it, and it's an online course, and it can be delivered by, the good thing is it can be delivered by lay personnel. I found it sometimes counterproductive on some of the code lavenders. Of course, everybody knew who I was, but to try to stress that I was a psychiatrist, at least early on in these interventions, because made the staff member think that we were implying that they were now having mental health issues and not a normal response to a traumatic event. The military found out the hard way, and they don't do this anymore. Of course, they do have to do a debriefing at some point, but not acutely on traumatic events, or what may have gone wrong, that kind of stuff. I know the Navy pilots would have a debriefing after they were involved in Middle East firefights over the ocean, that sort of stuff. And one of my active duty Navy persons told me that was one of the most traumatic things he ever went through, was an acute debriefing of the incident. Many times what they would do is they would get other people that were involved that weren't impacted psychologically, that were witnesses to it, to go over it. You know, it's interesting. My mom's boyfriend in high school back in West Virginia was Chuck Yeager. And so I got to know him pretty well later on, when both he and my mother were in their 90s. And he actually came to a family reunion in West Virginia one time. And he talked about, he was a decorated pilot in World War II, Korea, and Vietnam, and rose to the rank of general. And he said that was one of the most traumatic experiences that he'd ever gone through. And then Ted Williams, who, a great baseball player, he was also an outstanding fighter pilot in World War II. And he relayed to a group of people that his biggest memory of fighting in the Pacific was landing a Mustang on an airfield that had been napalmed, and he landed in the flames and jumped out of his plane before it basically caught fire and exploded. And they had urged him via radio to eject, and he didn't do it. And they asked him later on, why didn't you eject, Ted? And he said, this is kind of in the interim when a lot of athletes left baseball for 2 years, served the country, and then came back. And he said, well, if I would have ejected, I'm 6'3". If I would have ejected, I would have broken both my legs and never played baseball again. And so he says, I kind of risked my life to do what I did, and I'm glad that I did it. So I hope that answers your question, David. It was kind of tangential and circumstantial.
A quick follow-up, there has been interest in, rather than debriefing, which in essence would consolidate the memories and emotions of the traumatic event, treatments that are designed to prevent consolidation of memories, particularly emotional memories, following a traumatic event, in essence, sort of inducing a form of limited amnesia.
Right.
Any thoughts about that?
Yeah, actually, we had over at Columbus Springs with our active military and the paramedics and those sort of things. We had a therapist that was trained in EMDR, and we used that 4 or 5 times over there pretty successfully. Group therapy really helped a lot. But the word debriefing really kind of raises the hackles on some of us that work in this area, because it just has a bad connotation. And so we never really used that term with our Code Lavender program at all. We never called it a debriefing when we talked to the staff member who had been traumatically impacted.
Dr. Campbell, there's a question on the Q&A function. Can you see that? Do you want me to read it out to you?
Yeah, I read it out. I don't see it here.
Okay. It says, thank you. It's from Arthur Leva, is one of our PGY3 residents. Thank you for the talk, Dr. Campbell. From a personal experience, one of my co-residents was assaulted on the unit last year. It unfortunately was not severe. She had no major injuries, just a bruise. But seeing her get assaulted definitely made me more jumpy for a few weeks. I do think one of the helpful things, at least for me, was talking about it afterwards with the attending, However, we focus more about going through what we could do differently or changing the unit to make us safer. So
that's right. And I think that if you become proactive and you try to solve the problem and maybe form an ad hoc committee to look at these sorts of things, that's helpful. I think I highly recommend to the residents and the medical students out there that they get involved in a mentoring program. I know the students have that. I'm pretty sure we have it. Everybody is assigned a supervisor, and I would stress a great deal to. I would stress a great deal to utilize them as much as possible.
So a reminder to all the attendees, please use the Q&A function for any questions or comments. Unfortunately, we can't move everybody over to the panelists section.
There are some hands raised. Let me see if I can bring them in. I've tried to promote them to panelists, but let me see if this will work. So Dr. Adams, I've turned on your microphone.
Yes. Can you hear me?
Yes.
Okay. I'm a child and adolescent psychiatrist, also treat adults. And I found some interesting things about certain types of personalities are more prone to have post-traumatic stress problems. Do you find that in your work?
Yes, many of the people that we interceded upon had pre-existing trauma, whether this reminded them or not. It's, you know, PTSD can be like the layers on an onion, and you know, you kind of have to peel everything back. One of our nurses in the operating room that was very traumatized by an event that happened in the operating room reminded her of being physically and sexually abused as a child by her stepfather. And so that's a tier 3 thing. She'd never had any therapy for it. And she started out in EAP and ended up in some pretty long-term therapy with a private therapist in town that we set up with her. So yeah, I'm convinced that there are certain personality types that are infected. They tend to be more introverted, maybe prone to a little bit of neurosis. They may have an unspecified personality disorder. One of our impacted people had a diagnosed history of a borderline personality disorder, and this really raised a lot of problems with her. And she ended up going back into DBT therapy there in town.
Because what I found is that very high achieving, perfectionistic people who are assertive and who want to improve their lot in life, these are the ones that get traumatized more easily.
Yes.
Because they think that they can control a lot more in life than they can actually control.
Right. A lot of them have some obsessive compulsive quirks to them, that sort of thing. And it gets kind of back to the heroic aspect. If you think that you're immune to any of this, you're not. And so, yeah, that's a real problem. I agree with what you say totally.
Yeah, I use it in psychotherapy to help them understand the way their personality formed and how that impedes the getting into the PTSD. And if we can unravel that in conjunction with their type of personality, which I call an omnipotent personality, then they get better.
Yeah. Yeah. one of our active military personnel that we really couldn't do much with, we sent down to Emory, which is, as you know, is one of the pioneers in the virtual reality treatment of PTSD. And that helped him considerably. I mean, he was wearing these 3D vision goggles and reenacting a firefight, and realized through it that the people that he thought he had failed, there was nothing he could have actually done to help them, and it helped him a great deal.
Thank
Well,
you.
Rob,
Yes.
for everybody on our faculty or residents, Raymond Perry over at the VA has become quite interested in PTSD, and I'm sure anybody could call Ray up if they have a question or a problem with that sort of thing.
Oh yeah, absolutely, absolutely. I don't know if they ever formed it after we formed our Code Lavender program. About 6 months later, Norton contacted me, wanted to know if how to go about setting one up there, and so I gave him some resources and some guidelines. One of the best programs in the country for this was actually started by a pharmacist over at the Children's Hospital here. We have a very good nationwide Children's Hospital, it's called, and it was initiated not from a mental health worker. What happened was that a very beloved older gentleman over there who was the shuttle driver bringing people in from the remote parking lots to the main entrance. An 80-year-old lady accidentally just stepped in front of him out of the crosswalk, and he hit her and killed her. And he didn't know what to do with his trauma. And so they got him some help, but that's when their program started. And yeah, like I said, they had one of the best training programs in the country there.
Dr. Rabbani, I believe, had a question.
Okay.
Yes, hi, and thank you for this talk very much. I am a retired psychiatrist, as some of you may know. And I think that most of us as psychiatrists or nurses, psychiatric nurses, we have had these kind of experiences. And we have had to some degrees of PTSD type symptoms with that, that we kind of self-treated ourselves. Maybe very, very short debriefing, or somebody, a supervisor or someone talked to me. I had few patients who committed suicide when I was working inpatient, outpatient. I was in child psychiatry when a psychologist, a student with us, when we were talking, he had diabetes and he fell, and we gave him CPR, and that affected me so bad. I was feeling so bad about that scene and this and that. But kind of we were, I and maybe so many others like me, feeling responsible. Even one day I didn't take off, although I was stressed and I was uncomfortable and I was depressed, but I could keep that problem in one side of my mind and work and do my job also, not to take off and these kind of things. So I wonder about that, because if, the people can take off for this, like sick leave or maybe, then how can they find personnel to do their job? That came to my mind. Something.
Yeah, we, like I said, we have so many traumatized people at this hospital, workers. They are given an indefinite period of time off. They have, we get a lot of vacation time, we get personal time, we get sick time, and they will extend it. We have one person that's been off for 6 months with pay, dealing with this. They're determined to come back to work, but only when they're ready and they get cleared by their psychiatrist. So yeah, I think that's it's talking about traumatic events on the units. 2 weeks ago, I had a patient who was everything that said on the paper looked like she was ready to go. She told me that day, she says, Dr. Campbell, I'm not suicidal, but I'm having this, what we would call a feeling of impending doom, that something is going to happen to me if I leave here. So I canceled her admission, or her discharge. And about 3 hours later, she collapsed, and I ran over to see her, and kind of using my old cardiac surgery skills, I determined she was having a massive MI. She arrested, we resuscitated her. The paramedics came and took her to the hospital. They rushed her to the cath lab, did an angioplasty on her, put a couple of stents in, put an aortic balloon in, went to the ICU, and 2 days later, she still died from cardiac failure. And that greatly traumatized our staff who were involved on this. And I remember when I was an intern at Norton, we had a patient that had been there a long time that we could not link anywhere, and he stayed for a long time, and he had end-stage cardiomyopathy. And so what we did, it was Dr. Ballou and some of the residents and some of the senior nurses met with the staff and say, we need to prepare you in case he dies on the unit. And he ended up dying on the unit. But they had been prepared for that psychologically. His family was very grateful for what we're going to do. There was no medical treatment that could be offered to him. He was too old for a cardiac transplant, that sort of thing. So traumatic events like that are, we don't normally expect psychiatric patients to die on the unit or to become critically ill on the unit, because that's not really kind of what we do. We take care of critical psychiatric issues, but not too many critical medical issues on there. So it can be very traumatizing.
Thank you.
You're welcome.
Dr. Reese posted a question in the Q&A. Did you find a difference in frequency of utilization by different specialties with the Code Lavender program at UofL?
It was mostly nurses. We had occasional doctors, but you kind of taught that in the old school system, especially the surgeons, to be cowboys, to just suck it up. But having gone to grand rounds every week with surgery at UofL, Dr. McMasters had started this mentoring program that was recommended by American College of Surgeons because of the problem with surgeons burning out in their 40s and 50s from the stress of their practices. And so, like I said, mentoring and utilization of all your mental health care resources is greatly recommended, I think, to help circumvent these problems. But most of the people we took care of were nurses or other ancillary staff, some social workers, a couple of environmental. We had one environmental worker who would stop and go in every day with a patient that he had bonded with, and that patient ended up dying in the ICU. He was greatly impacted and utilized our services pretty extensively.
Any other questions, comments? Thank you, Dr. Campbell, for your presentation this afternoon.
Thank you very much.